I yeah, I just was wondering. So most of you are just starting your clerkship right now. Is that correct? So probably not many of you have much of exposure to radiology and reading X-rays. And just want to preface that there are no expectations at all, and this is purely just for uh, learning and making you interested in the field of radiology. And in general, no matter what kind of specialty you pick, you will actually encounter lots of basic imaging almost in every specialty. And especially chest radiographs is a workhorse of a lot of different specialties of medicine, like internal medicine or emergency medicine. So the goal is that by the end of your medical school, you'll be comfortable with interpreting basic chest radiographs and some basic radiographs in other body parts like fractures and abdominal radiographs. And usually uh, the radiographs might look a little bit intimidating in the beginning, but actually they're very interesting to solve. They're kind of like a puzzle. So I find this is the most rewarding part of radiology, is that you get to really see a lot of those puzzles that you solve, and you try to help your colleagues in other specialties. So when we start thinking about imaging, and in this particular case today, we'll be talking about chest radiograph, we have to really kind of first understand the physics of it and how it really works in this case. So as you probably know, X-rays, they use X-ray radiation, and the idea behind that is the ray of the X-rays is just hitting an object that is static, and in this case it's the chest of the patient. And depending on the different densities of the different parts of the body, the rate of the deflection of the X-ray particles will be different, and that's why you have different densities and different shades of white, gray, and black on your radiograph. So maybe in order to make it interactive, we can always get someone to answer. So I'll just ask some open questions, and anyone can just feel free and answer it. So when we're thinking about radiograph, and we're seeing the the brightest parts, the widest parts, are those the ones that have the highest density or the lowest density?
Those would have a higher density?
Yes, exactly. Very good. So respectively, the darker parts would have the lower density. And if we think about different tissues that different body parts have, so we have muscles, we have bones, we have fat, we have lots of fluid in our body, and we also have some gas, so some air. The reason why chest radiographs are really useful is because there is a lot of contrast created by the lungs, and therefore the air, which are the least dense parts of the body, they will be the darkest, and they create this contrast against the ribs, against the heart, against the mediastinum, against the soft tissues, and that creates this opportunity for us to see pathology very well, because usually pathology in the lungs won't have as much of air. Usually it's going to be denser, and because of this contrast, we'll be able to see it. So another important thing to note is, and that applies also a little bit more to CTs, which are essentially just 3D radiographs. They use the same physics principle. It's just X-rays coming from different angles and creating more of a 3D image that you kind of cut into 3 different planes, and you can examine it. So if you think about the density of fat versus water, which one is more dense? Fat versus like simple fluid like water or blood? Does anyone know? So yeah, so fat will be usually less dense. Fat is going to float, and that's why it will appear a bit darker than the blood or the fluid. So that's also another useful way to tell apart different fluids in your CT examination. Like, it applies less to radiographs, but in CTs you can tell very well whether you have fluid or it's actually fat, which usually is a bit darker. So without further ado, we can look closer at the anatomy of this chest radiographs and talk a little bit about the approach. So generally speaking, as you start early on with chest radiographs, you want to be very systematic and you want to make sure you look at everything. Everyone has their own method of looking at things. There is no universal right way to really examine a chest radiograph, but the only right way is that to make sure that you include everything in your examination, so you look at everything. So the order doesn't really matter. This is more going to be up to your habit or your preference, but generally speaking, we can, for example, start looking from the center and go outwards. So usually in the center we have the heart. So this is the heart contour. And important thing to note is that on all of the radiographs, it's going to be very confusing because the left and the right are kind of counterintuitive. So you always have to be mindful when you say right and left on the radiograph, and same thing on the CT. And it's okay if you mix it up. Like everyone mix it up from time to time. I forget about it. It also gets really confusing in real life when you're giving directions to someone and you're still in your radiological mindset and you're mixing up the directions. So that becomes sometimes really tricky. So the important thing is, like, to note is that the patient is kind of facing you on the radiograph. So their left becomes your right. So that's why we have the heart contour more on the kind of more on the right side from us, but it's actually the patient's left. So we call this the left side. So this would be the left hemidiaphragm. This would be the right hemidiaphragm. This is the heart contour. So this heart contour is actually going to be important to discuss because it's not really including just the heart by itself. It also includes a lot of other structures that you can't really see very well if you're not looking for them in particular. So what else is hiding here is that we have a little bit of lung hiding behind the heart. We also have a little bit of pericardium encasing the heart. We also have some fat, pericardial fat, some soft tissues that make this contour a little bit smoother. We also have the major vessels. We have the aorta, which goes kind of here, if you see my pointer, and then it goes down there. So this is the ascending, and here we have the aortic arch. Here you see this circle. That's usually the aortic knob, where the aortic arch involutes and goes, becomes descending aorta. We also have the mediastinum, which includes the trachea here, which you can faintly appreciate as a dark, more like a lambda-shaped, like Greek letter lambda kind of structure, or like an inverted Y, if you can think about it. So here, the bifurcation point you can see here, that's the carina. It's usually a little bit easier to see on actual workstation or if you're looking at the actual X-ray, but it also takes a little bit of adjustment to see it very well. Here, I agree, it's like very faint. It's a bit subtle to see, so you just have to probably believe me that there is a very, very slight contour of carina there, and that's where the trachea is splitting into the left and the right main bronchi. And we also have our hyla here bilaterally with lots of pulmonary vessels. So like pulmonary arteries are facing us. That's why you see a lot of haziness here, and that's normal. So oftentimes when I was just starting out, the primary abnormality would like kind of overcall a lot of times. It's just thinking that there's a lot of hilar lymphadenopathy or something, but oftentimes this is just very prominent vessels, which are totally normal. we'll get to see a bit more of cases later on, and you'll probably see lots of those where you actually do have hilar lymphadenopathy or something else in the mediastinum causing a bulk. But in this case, this is like quite unremarkable here, as we can see. And what else we have in the mediastinum? We also have esophagus, which we can't really appreciate very well here, but it's just hiding there. We also have the vertebra, which are creating this high density. That's why they're creating a lot of this white, like very bright structures, which because bones are the most dense things on this radiograph. So we can faintly appreciate the vertebral bodies, and also we can see how the vertebra create these different lines, which are quite important. So if you have any disruption in these lines in the cardiomediastinal silhouette, this can clue you in that there might be something happening obscuring this cardiomediastinal border, and you might have some sort of a pathology inside the lungs or inside the mediastinum that sort of disrupts this nice straight lines. So next we can move on to looking at the lungs themselves. So lung fields are usually on a frontal radiograph, it's going to be difficult to really localize to a particular lobe. And if you recall the anatomy of the lungs, we have usually regularly, like in a normal anatomical variant, we have 3 lobes on the right side, and we have 2 lobes on the left side. So on the left side, we have the upper lobe and we have the lower lobe. And we also have the part of the upper lobe that's called lingula, which kind of wraps the heart on the left side. And then on the right side, we have the right upper lobe, right middle lobe, and then the right lower lobe. So on this radiograph, it's a bit hard to really appreciate the fissures, but sometimes you can actually see it very well, especially if there is a lot of fluid in the lungs. You can see very well some of the fissures, and on the frontal radiograph like this one, you can see the minor fissure of the right lung, which would separate the middle lobe from the lower lobe. And also on the lateral radiograph, you can see quite well usually the major fissures of the left and right, which cuts diagonally the lung into the upper and the lower lobe. So usually to localize the lesion very well, we need 2 projections. We need lateral and frontal at least. And that's why it's going to be very difficult to tell exactly where the structure is just by looking at a 2D image like this. And also, finally, we need to make sure we remember about the bones and the soft tissues. So, and also very important, the abdomen. Just going to address it in order. So bones, let's start with bones. So we can count the ribs. We need to make sure that none of the ribs are fractured. And also the ribs are sometimes a little bit tricky because you only see this part of the rib very well, but there is also a second part of the rib which goes diagonally here. So as you know, the ribs, they curl back into the sternum, and in this case, we see here very well all the posterior ribs, but the anterior ribs might not be as intuitive, but they're still there. You also need to check for those. And sometimes those anterior ribs might be so faint that they might create an illusion of like a consolidation in the lung, but you need to make sure that it's something real, and it's not just like a shadow created by an anterior rib. Also, we have a lot of other bones that the chest radiograph will capture. So for example, we have the clavicles, we have the scapula here. We also have a little bit of the bilateral humeri. So we can also notice any abnormalities there as well. And also we have the soft tissues. So soft tissues are also sometimes going to be creating visual illusions for you. soft tissues are notorious for creating faint lines that will trick you into thinking that there might be a pneumothorax or some other lung abnormality, but you have to be very mindful what are the overlying soft tissues. So for example, here we can appreciate that this patient has prominent breast contours. So this could be a female patient or a male patient with gynecomastia. So we can clearly see that there are some soft tissue structures that you can notice. Also, there's like a skin fold here as well. So those are important to note. And finally, the last but not the least is the abdomen. So abdomen is important because on the chest radiograph, we can actually see the pneumoperitoneum. We can see a faint black line that will outline the hemidiaphragm, especially on the right side. It's going to be very well seen because it's going to be against the liver. And that will indicate that there is air inside the abdomen, and that can indicate some serious pathology like a perforation or some other acute abdominal problem. And also sometimes you can notice some things on the visualized abdomen, like maybe dilated bowel loops that will prompt you to look closer into abdominal x-ray and perhaps investigate a potential bowel obstruction. So that, and also of course, not on this radiograph, but on any other radiograph, it's important to note of any devices or any external or internal medical devices that the patient might have. You will see plenty of those, like pacemakers, different shoulder arthroplasties, whatever. And also, I kind of forgot to mention it early on, but it's always important to look at the age and the gender of the patient, and also a little bit about the indication why they're coming in. So I should have probably done it in the beginning, but I just jumped right away into the radiograph. But here we have a 61-year-old female patient with cough and weight loss. And you appropriately order a chest x-ray, which is a very good first step. It's very efficient, time efficient. It's usually very fast. The radiation dose is very low. And you can actually eliminate a lot of pathologies or rule in a lot of pathologies just with a chest radiograph. So you order a chest radiograph and you get this image. Let me see if we have more. Okay. And we can kind of go over some of the prompting questions. But first of all, does anyone notice anything abnormal about this chest radiograph? Any volunteers?
There's like, it looks like an opacity in the right lower lung.
Yeah, very good. Yeah, so I think this circular structure here is definitely concerning. It's not something that you'd expect. Also, you notice that it is asymmetrical, so it's not something that you would really expect perhaps in a soft tissue. We can't really say with conviction that it is inside the lung yet, because we only have one view, but it certainly could be in the lung. It also could be in the soft tissues. It could be probably pleural based as well. Could be less likely arising from the rib, because we kind of see a little bit of a contour of the lesion overlapping with the, like, it doesn't really blend into this rib or like neither of these ribs, but certainly bone abnormalities could be early on included in your differential if you're considering this, but definitely this would be concerning for potential some sort of a lesion in the right lower lung zone. So let's see what kind of questions we can discuss. All right. So we kind of talked a little bit about the organized approach to reading chest X-rays, and we talked about the abnormalities. And yeah, let's maybe talk about characterization, which is also very important. So how would you characterize this lesion? You can talk about its density, you can talk about its shape, its borders, and I can help you with using the proper terminology that will make you sound much more kind of knowledgeable about radiology. So how would you describe this lesion? Is there anyone who would like to volunteer?
I guess the shape is oval and
All right, very good.
the
Yeah,
borders
sure.
are a bit hazy.
Yes, yes. Okay. And
And
how
it
would you
is
describe the shape of this?
more opaque. More like oval,
Yeah, very
circular.
good. Very good. And what about the shade of it? Like, is it bright or dark? Like, do you know how do you call like more of the brighter lesions on chest radiograph?
Opacity.
Yeah, yeah, that's a good way to call it. You can definitely call it opacity. There are certain way like different ways to call it for sure. Opacity is a very like a valid term here that you could use. You can also call it like a hyperdense lesion. So or because like you know that anything that's bright on chest radiograph will be dense. So you can confidently say that this lesion is denser than whatever is surrounding it. You can also call it yeah, like a radio opaque, like an opacity exactly. And if you're seeing something like, let's say you saw something that was black, like completely dark, and it was darker than the lung background, how would you describe that lesion? Do you know like a term for that?
Lucent?
Yeah, very good. Excellent. So lucent is a term that you use for more dark lesions in comparison, like relative to their surrounding. Or you can also say like hypodense as well. And about its shapes and border, I like how you said it's oval. You can say it's well circumscribed because you can tell very well that there is the border of this lesion. You can also say that it's fairly homogeneous. Like you don't really see any internal lucencies or cavitations. I guess you could also say that, I don't know. Yeah, I think that's like a fair way to start with this lesion. Yeah. And now localization. So for localization, and I touched a little bit about it before, but we certainly would need a lateral radiograph. We can't really confidently say that this lesion is within the lung or it's within the chest wall. So we need to see a lateral view. So yeah, this is they put the arrow sign, which is a very useful radiological sign, and yeah, it's just talking a little bit about the different zones. Yeah, yeah, very important. Like I've also forgot to mention, but pleural is kind of like a separate entity from the lung. Like even though you might see something in the lung zones, or like overlying or obscuring the lung zones, this could still be in the pleural cavity. So like you need to pay attention to your cardiophrenic angles here, whether they're blunted or whether they are sharp enough. And yeah, so we discussed a little bit about what are the possible locations, and we can't really definitively localize the abnormality without having a little bit of context. Yeah, so this totally like might be correct, but also you can't really bet 100% on it that this lesion is within the right lung. So let's get a lateral radiograph. So how it works with the lateral radiographs is that essentially you have two axes, like two cross sections throughout the body, even though like radiographs aren't really like true cross sections. They're kind of like amalgamated image of everything that the X-ray beam encounters on its way. But still, you can fairly tell fairly precisely where the lesion is if you have two views. So on the lateral radiograph, the anatomy is a little bit different, but it still follows the same rules, anatomical rules. So we have anteriorly here the heart, the like the cardiac silhouette that includes also other structures. you can see fairly well the aorta here, how it takes the turn with the aortic arch. You can also see this hilum that essentially contains the pulmonary vessels, like the pulmonary artery. You see very well on the lateral view. Lateral view is really good for the thoracic vertebral bodies. You can spot lots of abnormalities on lateral view. And you can see very well the pedicles and the kind of the spinous processes and the transverse processes. You can also see the lungs here. You can see here that we have a little bit of darker area, which is totally normal, and this is actually expected. If you stop seeing a bright area in this part of the lung, or like not the lung, in this part of the lateral view, this might point you to several things. It might point you that there might be some anterior kind of lying pneumonia or like consolidation or whatever, some mass inside the lungs. But also importantly, it can also point you to mediastinal mass. So this would be the anterior compartment of the mediastinal. And there are certain things that are very, very important differential considerations for anterior mediastinum, which we can touch upon a little bit later. This is more like the middle mediastinum, and this with the vertebral bodies, vertebral column. This would be more of the posterior mediastinum. So a lot of posterior mediastinum can also have a lot of masses and abnormalities that can arise from there. And of course, we have a lot of soft tissues here as well that we can visualize and that can help us to further localize the lesion. So we really can't see any opacities in the soft tissue. We don't really see anything in the, like this area is pretty well preserved. Like this is probably just a rib, and all of this is still quite dark. Here we notice, so this is the part of the lung that contains the lower lobe. So the anatomy works this way, is that the major fissure cuts this diagonally into two pieces, and on the left side it cuts it on into the left upper lobe and the left lower lobe respectively. On the right side you also have the middle lobe here, which is cut by the middle, like the minor fissure. So there are also ways to tell whether you're looking at the right or the left diaphragm on the lateral. So the reason you can tell which one is which is usually with the help of your heart. So heart usually will abruptly stop the left hemidiaphragm, and here I suspect it's more like this one, and this one kind of is more continuous. It goes, overlays the heart, and this is probably the right hemidiaphragm. So this part is really good for spotting trace pleural effusions, which can layer in the cardiophrenic angles. Also, this area should be progressively darker as you go from the top to bottom. So here we have lots of soft tissues, we have bones, we have muscles. They all obscure the lung apices, and the lateral view isn't really good for the lung apex, like the uppermost part of the lung. But as you go lower, you are expected to really see less and less of these like opacities. Like you are supposed to see more darkness, less of these bright spots. And if we look here, and we kind of try to correlate where our hilum is, it's like here, but here we notice there's a bit of maybe some opacity. Like it's a little bit more than expected, the amount of hyperdensity here. So I guess like this would be quite suspicious, and this could, if we localize it to the area where we saw on our radiograph, it's on the right side. So this could certainly be suspicious because it's also in the lower lung zone. So we kind of localize it to that area. All right. So yeah, let's see some other kind of questions. So we kind of localize it to the lung fields. We don't really see anything in the soft tissues or in the bones. The bones look quite well preserved, and probably would be the right lower lobe. And also, in terms of the management, and yeah, so exactly in terms of management, obviously in the lungs, chest X-ray won't be conclusive for a lot of things. Like it will help you with things like pulmonary edema or pneumonia, but if even pneumonias can oftentimes be tricky because you can have a cancellation, you can have a like hyperdense opacified lesion, but you don't know whether it's a pneumonia or it's a tumor, especially here, which is very well localized. It's very like difficult to say exactly whether this is a pneumonia. In fact, like this looks more like some sort of mass. But there's going to be situations where pneumonia can be caused by a tumor that's underlying it, especially in older patients. That's why it's very important to get also a serial follow-up. So once you get your initial radiograph, clinically, it's important to get another radiograph in 4 to 6 weeks to ensure that whatever you did to treat your pneumonia, it actually resolved everything and there is nothing left behind. There is no mass that caused this pneumonia in the first place. And that's why it's important to also always check back with the prior images that you have on file. So in clinical scenarios, it's always good to look for any priors. And this is always like a right answer if you're prompted about like what would you do further on investigation of this. Like always check your prior examinations. So yeah, like we can talk about like the more interesting part now about the kind of like the differentials and what are things that you might consider. I touched a little bit about it on it, but what are some things that you can expect to see within the lungs that can give you this very well localized circumscribed lesion?
Maybe
Could
like
be
a
cancer.
tumor?
Anyone?
Oh.
Sorry, a cancer. Yeah, very good. Yeah, mass for sure. Mass would be probably the most common thing that will give you a very well circumscribed mass. Any other ideas? So at this stage, of course, like it's very early, and I think thinking in broad categories is always great. So I like how you thought about neoplastic causes cancer. Like, of course, like it's still very difficult to say what exactly type of cancer it is, and it's not really the point of the chest radiograph. It's more just to alert you and to really get you to prompt more investigations down the line. But other things that you could potentially consider is, so pneumonia, as we talked about, it would be a little bit more hazy, but still could be, especially in pediatrics, like you can have very round kind of pseudotumor-like mass-like lesions in children, and pneumonias in children can look like this. Also, you can have not necessarily cancer, but like a benign lesion in a lung. You can also have some arteriovenous malformation, which is also probably like along the lines of a vascular malformation. You can always think about those. You can think about some perhaps lung abscess wouldn't look like this. Lung abscess would have a little bit more of a cavitary appearance. So that wouldn't necessarily be the first thing that comes to your mind, but still important to keep in mind to look what different things look like on radiographs so that you might be aware of. And yeah, and like nodules also from different other kinds of disease, not necessarily just cancer. So yeah, so we did this. I did this. Okay. And in terms of next steps and management, so if you're expecting a mass, which is a cancer, we probably want to investigate it further with CT. That's usually the best modality for lung-based pathology. For other organs, you would use other modalities, not necessarily CT, but usually CT is always a very good first step in terms of investigating things that are not really easily answered just by a chest X-ray. So you can do a little bit more practice here. So what about this one? This actually radiographs is pretty interesting. This one has a lot of other ancillary findings and small things that are a bit unusual compared to the first one, which looked fairly normal, other than that lesion. So once again, we have something here, which looks like it has a very well-defined contour. It's hyperdense. It has a little bit of lucencies within it, and has a bit of like those lobulations. You can see the kind of like smaller circular components, I would say. And we see it projecting over the right lower lung zone, but once again, we don't know for sure if it is in the lung. We also note that this patient has a lot of like other small findings. They probably had a heart surgery because they had sternotomy wires. They also have a little bit of scoliosis, as you can see. Like it's very mild, but I think their vertebral bodies are aligned a little bit. They're a bit convex, or it could be also the position. It could be that the patient themselves is a little bit rotating, and we can see that they probably have a lot of kyphosis as well because their clavicles are really, and like there's a lot of crowding of the ribs here, and also the clavicles are projecting further here, and then yeah, and nothing else really to stand out. But this certainly is something that we want to further localize. So as we kind of talked again, this could be in the lung, could be in the chest wall, could be in the ribs. But once again, it's not very convincing that it's in the ribs. I'll probably say more like the chest wall or lungs. So I'm gonna get the lateral, oh, sorry. We're gonna get a lateral view. And as we can see, it turns out to be not quite in the lungs. It actually turns out to be in the breast tissue. So this certainly could be more along the line of a breast lesion. And it looks like it's quite dense. And usually what gives you density in soft tissue is calcifications. So this looks like a very calcified nodule or a mass in the breast. And this would probably prompt further investigation with like maybe mammogram or um, like you will learn later. It's not definitely way above your level of training, but some breast lesions can look a bit more benign. Some look more aggressive, and yeah, certainly like they might need to have this investigated furthermore. Oh, so I noticed there's a question in the chat. Let me just open it and I can answer it. Yeah, so could we say that the heart is hypertrophied in this patient? It seems larger than others, but not sure. So that's actually a great question that is good that you ask, because there actually is a reason why this heart might be enlarged. Because if you look attentively, okay, let's look first at this one. So here we have, they don't really say, but most likely this is a PA view, which means that the patient is positioned with their chest kind of against the film, and the X-ray shoots through, and they get the heart, like if you think about it from the physics perspective, kind of the heart produces the least amount of reflection and produces the least amount of magnification bias because it's so close to the to the plate, like the film that against which the patient is standing. But here, if we notice, this is actually an AP scan that is mentioned in the description here. So probably what happened is, oh, sorry, I keep clicking on the wrong side. So probably what happened is maybe patient wasn't really mobile, they were in the stretcher, and they probably maybe did a portable radiograph, or for whatever reason, they had to be lying on their back, not on their chest. So that's why this will actually exaggerate the heart, because the heart is located further away, and there is more of this dissipation of X-rays, which on the eventual film is going to create like more of the magnification bias. So the AP radiographs actually known to artificially enlarge the size of the heart, so we can't really conclusively tell if there is cardiomegaly. So the term for hypertrophied heart or like generally increased cardiomediastinal silhouette, well, specifically cardiac silhouette, is cardiomegaly, because cardiomegaly doesn't necessarily mean that it's just the heart itself is hypertrophied. It certainly could be, but it also could be that there is lots of fluid in the pericardial sac, so this could be a pericardial effusion with a normal sized heart, or this could be perhaps or like a dilated heart, not necessarily hypertrophied. So could be like lots of reasons, but all of this can produce cardiomegaly. So the best term to use is cardiomegaly, but this is very, very good that you notice this hypertrophy. Yeah. So it's not actually like a real thing, but very good to notice. Okay, and yeah, we localized this essentially. Yeah, and we can also kind of confirm here in the lateral view that this patient probably has a lot of kyphosis, as you can see in the thoracic region. We can also see they have some valve replacement, and I'm not gonna go into how to localize valve, but this is essentially like there is a ways on radiographs to tell which valve it is, but it's a bit more advanced. But that's why they had a cardiac surgery. That's why they had this sternotomy, and they had this valve inserted to treat their disease. So it could be certainly that they might have a bit of cardiomegaly, but I wouldn't necessarily call it from an AP, just because it's an AP view. From a PA view, for sure, yeah, you could maybe say it's pretty large. Yeah, you can say that it's borderline enlarged, and the cutoff on PA radiograph is usually more than 50% of the thoracic diameter. So you kind of measure the lungs from one side to another, and then you measure the heart. And if it's more than 50%, then you have cardiomegaly on your radiograph. Okay, so we talked about these two radiographs. I don't think we have any other radiographs included, but let me know if you have any questions, or how did you find this talk in general? Like, did you find it helpful, or anything that you would like to discuss or ask about, or we can do more practice for a little bit.
I was just wondering if you could review how on the lateral scan, I know you mentioned like there was a way to tell the difference between the right lung and the left lung, even if you're looking laterally. I was wondering if you could review that. I think I missed it.
Oh yeah, for sure, for sure. So if we look on this one, for example, so if you think about it anatomically, the right heart, no, sorry, the right hemithorax is not really obscured by anything, whereas the left hemithorax is kind of bordered by the heart. It has to envelop the heart, and that's why the left hemithorax won't go all the way anteriorly. It will actually stop at the heart border, whereas the right one will go all the way to the kind of like the anterior chest wall. So in this case, you see this line here? This is most likely like this one that continuously goes all the way here. That's probably the right hemithorax, sorry, the right hemidiaphragm. And this line kind of stops here. You can almost even see faintly this lung border. This would be the cardiophrenic angle, so the angle between the heart and the diaphragm. And this is most likely going to be the left left hemidiaphragm. So it follows here. So the left hemidiaphragm is a bit lower, also just by the convention, because the patient usually on the lateral scan will have the right side closer to the film. That's why it's going to be magnified less. That's why it will look smaller. The left hemidiaphragm might look a bit larger also, but that is probably less, I would say, less reliable, because like depends on how the patient is positioned. Most of the time it's going to be positioned in a conventional way, but the way to really tell it more easily is usually by tracing the diaphragm to the anterior chest wall.
Thank you so much.
Okay.
That was really helpful.
Yeah, for sure. All right. Any other questions?
I have a question. I noticed on the one we're currently looking at, the nodule was more defined in the APV. Like you could tell it had some topology. Yeah, so this one looks pretty. This one looks pretty kind of vague and white, but the next one looks very defined. You can see some lines on it. If you go down to the frontal view.
Oh, this one?
Yeah, it looks. You can tell it has like some wrinkles or whatever. Is that because it's closer to the surface? Can you tell how deep something is by looking at it?
That's a good thought, but I would say that's it's not really that indicative to the location. I think it's just by the nature of pathology, because as we found out later, this is localized to the breast tissue. Probably this is just maybe some like this is what like the calcified breast tissue looks like, because this looks like some mammary glands. That's why it looks a little bit lobulated and a little bit unusual. Like if it happened to be in the lung, I could think of some differential like calcified lung nodule, like a very large granuloma, which is like, once again, you don't have to really worry about it. It's like a benign mass, and also it's not really like a very introductory thing to really know about. But yeah, I think the shape of the lesion can certainly help you with the differential diagnosis if you know what different lesions look like, but it won't necessarily help you with localization as much.
Got it. And just a follow-up question, like for a study like this where the abnormality is kind of obvious, to what extent do you still go through your checklist and comment on like other things that you might see?
Yeah, for sure. Yeah, that's a great question. So I would say early stages, I would definitely go through all of the checklist. If I'm just kind of presenting the case to an attending, I would probably just focus on the main abnormality first, because usually, like unless they ask you about your approach to chest radiograph and they want you to go into great detail, I would just focus on the main abnormality first. But if you are actually like interpreting chest radiograph, it's always useful mentally just go through all your checklists and make sure that you don't miss anything, because you'll be surprised, like a lot of times you might miss fracture. Like for example, I was on elective at ICU in my medical school, and we were like rounding on an ICU patient for weeks. She was in ICU for like 3 or 4 weeks, and they were doing serial chest x-rays on her, and no one ever noticed that she had a chronic displaced humerus fracture, because they're all were focusing on the lungs all the time. Like there was lots of things happening in the lungs, but I just like noticed it one day, and they were like, "Oh wow, it's like we never even thought of it." Like, and it's not that it's gonna change the management as much in an ICU patient, but still, like you might spot a lot of things on the periphery. So always make sure you look for any incidental findings. Yeah.
Okay, thanks.
All right. Adjust my phone. Any other questions? All right, and I can show you some good resources for like medical students if you want to do more practice with chest radiographs. So there's this nice website which is kind of geared more towards medical student level. So this book is really good. I read it in medical school by the end of third year, and it has lots of really good like images and cases. This whole website is just has lots of practice of X-rays. Like you probably all know about Radiopedia. It's like good for looking up things. Like I have lots of things that I looked up on Radiopedia. Also, there is this really nice app from UBC that you can probably do it complete in a week or so, but it's really good for refreshing your anatomy knowledge and for just preparing yourself for not just radiology lectures, but like generally your knowledge of radiology. You can download it. It's just quiz format, very like highly recommended. And I think those are like the main websites or resources you can really use to practice radiographs. I think there's like somewhere a website where you can look at 100 normal chest radiographs. It's not really like I never really use it honestly, but if you want to have more practice at seeing normal things, which you will see actually a lot, like you can use it. Especially it's good to train your eye, especially as you are starting out, because you will overcall a lot of things, and that's totally normal. It's better to overcall things than to miss them. So always be like, don't worry about calling out things that turn out to be not there. It's a good teaching moment. Okay. Any other questions or things you wanted to discuss?
Okay, well, thank you so much, Dr. Pozdnyakov. This was a wonderful session, very detailed and great participation from everyone as well. Great questions. Thank you for your time, for your knowledge, and for the resources at the end. And everyone, thank you for attending. So we hope to see you again next month. Okay, everyone?
Yeah, thank you so much for organizing and thanks so much for attending. Yeah, it was a pleasure to see everyone and best of luck in your clerkships and pre-clerkships. Okay, take care.
Thank you.
Goodbye.